the scientific committee already. We wait for Dr. Damrat and Dr. Grengrai to confirm back on behalf of the scientific committee soon.
Lovely. Well, I appreciate everybody's flexibility at last moment. And I know these are not easy things logistically for the team to organize. Putting up with me for a week is not easy.
We have you and Liana that week. Dr. Liana, PI cancer. I think we have the time reach the 7 already. Maybe Alex can start.
Wonderful. Alex, are you able to hear and see us?
Able to hear and see you. It's saying that I don't have permission to share my presentation. Can you see me? Can you hear me okay?
I can hear you. I can't see you. And I wonder why you can't share.
I'm trying to see if we can do something on our end. Hi, everybody.
Justin, I forwarded the invite from my calendar
see.
to Alex. Might that have caused the issue?
It might have. I wonder if
It has me as the
Actually,
host.
on the beginning, I can see the slide shared by Alex, but then it disappeared.
do you want to try again, Alex? See what happens. Alex, I can re-invite you to the meeting too if you want to.
His email address, Justin?
Yeah, let me take it. Is it Heckman A?
Yeah, let me just make sure, but I believe that is correct.
Yep. Okay, I sent it to him as an invitation. Alex, I sent you the invitation again, but as a host, you should be able to share. I've got you, you're allowed to host, present, everything. Can you try it again?
I'm just calling him.
It says sharing this icon to someone's profile picture and the participant will make that person the presenter. You should be able to go,
We just re-invited you. So you should see an invite from Justin Denny. Okay, and so if you exit your current and rejoin via the new link. Okay. He's signing in through the new link.
Okay. Says he just went off. It should work this time. Let's give it a go.
Sorry for the delay, everybody.
He can also send it to me and I can advance the slides, of course. We've got a good team here today. Thank you all for joining. Sawadee krap. 26 folks.
Oh, Justin, sawadee krap.
I hope the weather's getting cooler in Thailand.
Raining.
Oh, good, good. I know you were hot for a while, so. Okay, Alex, we can see you back on again. You want to try and share?
ทุกท่านโปรดมิวต์ the microphone ด้วยนะคะ PUD mute please.
Okay, Alex, you've got privileges, so let's try and share it again. Alex, can you hear us?
Calling him. Otherwise, I'll start on my end as he figures out his end.
Okay. He just went off again.
Hey, did you get the new link? Okay. He's launching the meeting now.
Audio's connected.
Alex, try and share your screen. It should work now.
Okay.
If not, you can email it to me and I'll advance slides for you.
Okay, that may be a better option because it's giving me that same error message that I don't have permission.
Okay.
Let's try
Yeah, go ahead and email Denny J, DENNYJ @ohsu.edu.
Okay.
Where the last email came from.
So while you all do that and get that queued up, we'll reverse order and I'll go with a quicker case first,
Okay.
as long as I can share. Bear with me one moment.
So my file may be too large to present or to email. So let me see if I could work on my.
You can do it via OneDrive. I think Justin has OneDrive.
Okay. So Denny J.
Yep, DENNYJ @OHSU.
Okay.
Joaquin, can you share?
I should be. I'm doing it right now. Bear with me a moment.
Yep, here it goes. We see you now.
We see
See
the
mine?
spine.
See just fine.
Right now I am having issues because my mouse won't cross to my second screen. Never had this happen before. Everybody, my sincere apologies that both Alex and I are having IT issues.
Well, when it rains, it pours in Thailand.
Give me just a
It
moment.
happened to us before. When we present to you, it happened.
You can stop sharing if you want to stop sharing your screen, and then you can. There it goes.
Right. Can you hear and see my screen?
Yes, the 52 years old.
Okay. So I don't have a mouse, so I apologize. And once I finish, I'm going to have to log off and come back on because I can't access the WebEx. But I think I can do the case now. So this is a 52-year-old woman who was admitted with exertional chest pain and dyspnea. She had noted several episodes had occurred at rest, and therefore she was placed in observation status in our inpatient unit. She had no remarkable past medical history. She was on no medications, and her physical exam was notable for blood pressure of 128/72, heart rate in the upper 60s, and respiratory rate of 14. And she had a normal exam with the exception of a continuous murmur over her chest. Despite that murmur, her electrocardiogram and echo were both normal, and her laboratories, including BNP and troponins, were normal. Because of the absence of dynamic changes in the electrocardiogram, she underwent a stress test, but in less than 4 minutes, she stopped due to low functional capacity without any diagnostic EKG changes. And because her symptoms were so prominent, even though she was low risk, she underwent a CT scan, which was abnormal. I won't relay the findings. And as a consequence of that CT scan, then underwent right heart catheterization and coronary angiography. So I'm going to start with the right heart cath pressures. And her mean right atrial pressure was 5. Her PA pressures were 31/12, the mean of 19. She had a normal pulmonary capillary wedge mean of 8, V waves of 12, and a left ventricular end diastolic pressure of 10 without a gradient across her aortic valve. We did a saturation run, and her high and low SVCs were 67, 69. Her right atrial pressure, 69 and 68. RV pressure of 73. And her MPA increased to 77.3 with normal saturations in her central aorta. Based on Dexter's criteria, there was a step up at the level of the great vessel, and that is MPA. And she had a QPQS of about 1.7 to 1. And so we detected a left to right shunt at the level of the PA. And so we then proceeded with selective right and left angiography. And what we shouldn't be doing, selective injection of the conus. We came to the RAO view. Of course, now they are neither advancing nor playing.
Right, we are waiting for your moving angiogram. What is your clinical impression with the examination? Continuous murmur, is it machinery or what else? And clinical diagnosis is PDA or something else?
So it was not machinery. And so thought it was something else.
Do you have a chest X-ray to show for us? A chest X-ray and EKG that is a standard for diagnosis, at least for
They were
structural heart.
completely normal. And everything is frozen on my screen.
Have to stop sharing and sharing it again, Joaquin, for the size of it, if you just want to stop sharing and reshare again.
If I could get my arrow over the stop sharing.
All right. Why don't you log out and log back in again?
Going to do that. My apologies.
And the other presentations we have all ready to go. So,
Give me 1 moment.
okay, I'll let you go first.
Give me 30 seconds to try and troubleshoot this. Are you still seeing my screen?
Yes, we can see your screen and we can see the presentation with the side window outline.
Were you able to see it as a smaller?
Yes.
So when
Can
I
you-
try, and I'm going to try and do it large one more time to see if it,
Can you at least try and make it larger in that view there? Nope. Doesn't move on the large screen.
well, everything freezes.
So if you can exit out of that window and just make that screen as large, you can actually grab that bar and bring it down. It'll be a bit larger for us to see.
Yeah,
Decrease the
my
size.
arrow is not crossing the screen. That's the issue.
Oh, I see. Well, we can watch it on the smaller view if you like.
So what you can see here is a Judkins Wright catheter that was counterclocked, and it has now selectively engaged a large coronary fistula that starts right at the right coronary os and extends in this large, approximately 4 to 4.5 millimeter fistula that becomes serpiginous, and it empties in this vessel here, which is anterior to the aorta, and this is a main pulmonary artery. And this is now the left coronary, and it has a proximal fistula from the left anterior descending coronary artery as well into the MPA as well, and you can see it here. In the right coronary, we identified the area of the right in which the fistula started, and it becomes really important that we do so in this left. In this picture in the RAO, you cannot determine where it begins, and so now we have gone cranial, and again, you still cannot determine where it is. And now you see it. Here's a proximal LAD, and it is large because of the fistula. And then you can see right here the origin. And so these are two proximal fistulae that originate from the ostial right and the prox to mid left anterior descending coronary artery. And they are causing coronary steal, resulting in exertional dyspnea and angina without either PA dilatation or RV dilatation. And so the indications for closure of this for her are decreased functional capacity secondary to dyspnea and exertional angina. She's had no documented arrhythmias, no endarteritis, and no evidence of chamber enlargement or ventricular dilatation. And so she has symptomatic large fistula, and there's an indication for closure. And this falls under what I believe will be simple closure in the proximal origin that we will attempt to do by engaging the ostium, wiring it, and then with a mother and daughter technique, advancing a catheter well beyond the ostium and placing likely an Amplatz vascular plug 2. We'll start with the right, and then we will proceed with the left. And so we will instrument it antegrade through the actual vessel. And so this was a really interesting case. Because of the complexities, we did not do this ad hoc, but determined the hemodynamic significance of it. And then we present it within our congenital team. And then I will work with Grant Birch, who is our head of our interventional team, and likely put 2 AVPs. I don't think this is a situation that we'll have to access retrograde through the PA and cannulate. And I think that the proximal segments coming off the coronary are large enough that we won't need to do an AV loop where we access both from the arterial venous snare and create a rail. And I don't think we'll need to use any of the coils here. But really fascinating, and what tipped it off was, as Dr. Damros mentioned, the physical exam that led to an echo that, ultimately didn't find anything. And so in that differential of continuous murmurs are fistula, and that's what the CT demonstrated. And then we verified the hemodynamic impact. And it's pretty amazing to be able, by oximetry, to detect a left to right coronary shunt, because they've got to be larger than 1.5 to 1 to reliably pick it up by oximetry. But combined between the right coronary and the left coronary fistula, it's about 1.7 to 1, which is pretty impressive. And the PA was not enlarged, nor was the RV. So I thought it was a fascinating case to show you. I'm sorry that I couldn't get the entire large screen to show, but wanted to start with that as one of the more interesting hemodynamic coronary cases. The second chapter will be to show you the successful percutaneous closure, with probable AVP2s. And those images were acquired at 30 frames a second to show us the highest resolution. And when it came time to delineating the entry and exit, without panning, to improve the temporal resolution of the imaging. So 30 frames, and don't pan once you figure out the best views to look at the inlet and the outlet of the fistula. So have any of you closed fistula percutaneously?
Yeah, I do close, but I've never used the Amplatz, but I use multiple coil. For this size, maybe 6 or 8 coils at least minimum. And for me, to insert the Amplatz is quite be very challenging because of the feeder, because the feeder of the AV fistula, the feeder of the vessel.
It may turn out that we have to go to coils. We've done these successfully in the past of this size. especially the right coronary, where it'll be easy to actually cannulate the os of the fistula and, advance. The left will be a little more challenging because of the 90-degree takeoff from the anterior mid portion of the LAD. So stay tuned. Wish me well next month, and I'll show you some quick follow-ups with, I hope, less IT issues.
No worry, Prof. We will look forward to your follow-up on this.
Justin and Alex, are we going to tag team and have a better IT issue than what I just went through?
I think we should be okay. Can you hear me okay?
Yep.
Good, good. My video is not working for some reason, but I'm just gonna kind of roll with it, if that's okay with everybody.
Can you see the screen?
I can,
Yes.
yeah, thank you. So I have a pretty interesting case that we performed a few months ago. This is a patient, a 63-year-old male, history of heart failure with reduced ejection fraction in the setting of an ischemic cardiomyopathy with an ejection fraction of 20%. And they had known severe 3-vessel coronary artery disease with the known chronic total occlusion of both the right coronary artery and the proximal LAD. And there's also severe stenosis of the circumflex to OM bifurcation. So really last remaining vessel of this left circumflex and OM1 bifurcation. The patient's presentation, they had a severe limiting angina. They were only able to walk up a flight of stairs, weren't really able to do too much of their normal, ordinary daily activity, were having chest pain going to the grocery store and walking around, walking from their car to the grocery store, pushing the cart. So very significant angina, and despite 3 separate anti-anginal medications, a long-acting nitrate, metoprolol beta, carvedilol beta blocker, and ranolazine on maximum doses of each. Next slide, please. So during their evaluation, they underwent cardiac MRI to assess viability, and they found that there was no viability in the LAD territory. However, there was viability in the circumflex territory. And so at this patient underwent the heart team conference here at OHSU, and they found that they had a very elevated cardiac risk, or just an overall surgical risk score. So they weren't a good candidate for surgical revascularization. So ultimately, the patient was referred for high risk Impella supported PCI of this left circumflex obtuse marginal bifurcation. So next. And if you press play, you can. So these are the images from our neighboring institution that initially referred the patient to us. So here you have you'll see a short, blunt tip, or actually tapered tip, chronic total occlusion in this proximal right coronary artery. Next. So this is a Judkins left catheter injecting the left coronary system, and you see the significant disease. You see diffusely diseased, highly calcific, completely 100% stenosis of the proximal LAD. Do you all see that, or do you see a green?
Yes. No, we see it.
Okay, it's back. CTO, chronic total occlusion of this proximal LAD that we know has no viability, and then significant stenosis with these post-aneurysmal dilatation segments in the circumflex and the first obtuse marginal branch.
And then prominent septal collaterals to the PDA PLV, right, Alex?
Yes, that's correct. And here's another view that really does show those collateralization to the PDA. Next slide.
And it's surprising to me, if you go back, you know, as we look at the flow down the LAD, you know, there are extensive collaterals left to left that opacify almost the entire LAD, kind of in a TIMI 1 to wanting to be TIMI 2, that there's an absence of viability in that anterior wall. I would have expected and hoped for some viability in the anterior wall.
And then the previous slide, the one right before this slide, is the LAO-caudal view, which does outline, you see a little bit better of the proximal circumflex and obtuse marginal bifurcation. So you do see severe 80 to 90% stenosis at this bifurcation. Next slide.
เขาเห็นพวกเราทำเขาก็เลย
Was that a question? I'm sorry.
He was background, Alex.
Okay. So it continues. So the patient's characteristics had a elevated surgical risk score, ejection fraction of 20%. We were doing an intervention on the last patent coronary conduit, and it was considered a complex bifurcation with severe angina. Patient had normal renal function, and they had no echocardiographic evidence of severe aortic insufficiency or LV thrombus or atrial septal defect or ventricular septal defect. And then there was also no iliofemoral tortuosity or stenosis, and the diameter of the vessel was greater than 5 millimeters. So we felt the patient would be a good candidate for Impella-supported PCI. So here's our first picture after using
Just a comment about our Impella technique in these individuals. We do our standard ultrasound guidance with visualization of the needle, just superior to bifurcation, avoiding a calcified segment and attempting to stick at 12 o'clock. Typically, we'll do 2 pre-close sutures, you know, at 10 and 2, and then, you know, size up and advance the Impella device over a wire into the LV, and then optimize placement of the device initially in an RAO and then confirming in an LAO how the catheter is sitting above the sinuses, and look at pulsatility and flows as we ramp up the RPMs. For the lab-based use, in which we're not intending to continue somebody on MCS, we almost never do antegrade perfusion with a second sheath to provide distal perfusion to that extremity. For individuals who are going to leave the lab with the device for a prolonged period, or for our patient cohort that we support with ECMO, those universally we will place antegrade perfusion sheaths to minimize the ischemia in that extremity.
So in addition to what Dr. Figueroa mentioned, one thing that we do that is pretty interesting is our guide access. We will actually go through the 14 French Impella sheath. So we will use instead of having to go right radial access in addition to the Impella, we will actually use an access needle that will go in advance through the diaphragm of the Impella sheath. And then once blood returns through the micropuncture needle, we're able to wire the 018, upsize it to your sheath of choice. In this case, we used a 7 French 25 centimeter sheath, and then you wire with the 035 J wire, and then you're able to advance your guide over that. So in this case, we used an EBU 3.75 guide catheter through the Impella sheath. And so it limits the amount of access that we have to expose the patient to. So here's our initial injection. This is an AP caudal view. Really not much has changed from the previous images, but you do see that the Impella is inserted. Go to the next slide. And so this is an image of our run-through wire trying to navigate down through this tortuous vessel. And you see this kind of aneurysmal segment. The wire tended to prolapse into that segment. So had a lot of difficulty wiring into that obtuse marginal branch. You can see there's also a run-through wire that's down at the bottom of the screen that had been wired into the circumflex artery. But there was a superior takeoff, a very small channel that was superiorly taking off of that vessel. So it was kind of difficult to wire down initially. Next slide. So then what we were able to do is actually bring down a coarse-hair catheter, and we had a bend in the wire to where we were able to direct it upward and enter that superior branch. So this is actually a whisper wire. We did change a wire approach, and we were able to enter into that vessel and then advance the coarse-hair, and then we de-escalated our wire down to a run-through. So we had a soft tip wire in that that first obtuse marginal branch. So we had 2 wires in. And then so we started our pre-dilatation with a 2520 semi-compliant balloon that was advanced over the OM1 wire, and we pre-dilated to 12 atmospheres. Next slide. And then we ended up using a larger NC balloon, a 30 by 15 NC balloon. And then a 3515 NC balloon was then placed on the circumflex or second obtuse marginal wire, and then it was ballooned at that ostial segment, or that bifurcating segment. And then next we performed IVUS over that circumflex wire, and this helped with lesion characterization and stent sizing. And we did note that there was greater than 270 degree arc of calcium. It was actually almost 360 degrees, and a rather small lumen area. So we're already thinking in our minds we need to lesion prep. So we decided for shockwave IVL here.
So one of the things that I would comment, now that we have shockwave as a tool that we use for focal lesions that have not yielded, is how remarkable and how often it appears that the lesion yielded by a semi-compliant or compliant balloon in which you don't have a waist, but because the lesion is eccentric and you've not looked at it in 3 orthogonal views, how sometimes it appears to expand, but yet when you look at it with IVUS, you don't even see it cracked and recoiled. It just never yielded. And, that happened in this case. And then Alex and I were doing a left main ostial LAD circ, and the same exact thing happened. It looked like the LAD yielded, and by intracoronary imaging, it was a 360 degree arc of dense calcification, and it was like we had never been there, even though when we fluorostored the non-compliant balloon at 18, it looked like it had yielded, but it didn't. And so, as Dr. Damras always says, imaging, especially in complex anatomy, is often informative, and sometimes disappoints you because you thought you had gotten a gain already, but it was fool's gold. You hadn't touched the critical part of the lesion yet.
No, that's absolutely correct. Yeah, in some of these pictures, you just don't appreciate the waste, but on IVUS, it's very apparent.
Can you show me the IVUS images as you mentioned?
I actually do not, unfortunately, have the IVUS image for this. I apologize.
We had, Dr. Damras, we had to have people come and redesignate in our packs. Neither our FFR from our CathWorks nor our images from our ultrasound were coming in the same file packet into our PAC system. And so they're on site working on that as we speak. So my apologies.
So then this is a picture of the 3.5 by 12 shockwave balloon that was being inflated over the first obtuse marginal or circumflex wire. And 5 impulses were delivered here. And then that same balloon was advanced over the OM2 wire, and then also 5 impulses were delivered there.
And it's quite fascinating when you look post IVL, you almost see like these micropores, that penetrate through that calcified plaque and go deep. It's a fascinating acoustic image. It's very different than anything else I've seen before.
Okay. And then so with this is actually a 3.5 by 12 NC balloon that we use to for additional predilatation to crack open the remaining part of that calcified lesion. And so once we felt the lesion was prepped, we decided to move forward with our two stent technique. We had gone into this thinking that we wanted to do a DK crush technique. We figured this was the last remaining vessel. We knew we were going to have to do a two stent strategy. So we wanted to choose a stent strategy that would lower the risk of target lesion revascularization or even lower the risk of stent thrombosis. So here we chose DK crush over the culotte technique. And so here's our first side branch stent. This is a 3.0 by 26 millimeter Onyx Frontier. So this was delivered and deployed at about 10 atmospheres. And we had about 2 to 3 millimeters that protruded from that ostium into the first obtuse marginal. And so you see here that there's also a 3.5 by 12 NC balloon that we had previously used. It's still placed there. We'll try to size it 1-to-1 with the proximal vessel. And that way that when we inflate it, we'll be able to crush that small segment that's protruding. And so here is that main vessel balloon that I was mentioning that was sized about 1-to-1 with the proximal main vessel that was inflated to crush the protruding section. And also that prior to doing this, importantly, that side branch stent balloon wire let me rephrase that, I apologize. That wire that was in the side branch was withdrawn prior to the inflation. And then we proceeded with our first kissing balloon inflation. And here's a picture of that. And then the next...
Alex, may I interrupt you for a minute?
Yes.
When I do the DK crush, first, when we deploy the side branch stand, and we place a balloon to protect on the main branch. Before I do the balloon inflation on the main branch, I will do stent boost to make sure that part of the stent is on the main vessel. Do you have a picture of stent boost before you do inflate the main branch?
I do not, but we did use stent boost for that section or that part of the procedure.
So Dr. Damras, thank you for identifying our fourth and fifth PACS issue today. The stent boost also is not transmitting into our PACS system at the moment.
Yep.
There's an active gremlin.
Okay, and then, yep, and then so this next picture, this is their first cinematography before the next stent was placed. So we see this nice result that we had in that side branch. So the main vessel stent was delivered and deployed. And this is a 4.0 by 34 millimeter stent that was delivered. And this was deployed at 12 atmospheres. Go to the next slide. And then next slide. Could you actually advance one more slide? Okay, now go back. So, so I missed my final double kissing balloon inflation. So the slide before this, this slide that's showing here is our proximal optimization technique with a, I think this was, if I recall correctly, a 4.0 balloon. And the slide before this was actually our double kissing balloon inflation. Oh, there it is. Okay. And then next slide. There it is. And this is our final proximal optimization or POT balloon inflation. And then the next slide.
What size of the 4.5?
This was it was actually a 4.0. It was a 4.0 by 12.
I guess to do the proximal optimization, maybe you have to go to 4.5 at least. That's a huge vessel.
Okay.
What was your IVUS dimension? Did you use the IVUS to guide the 4.0?
Yes, so our IVUS dimension was a 3.7 to 4.2, if I recall correctly, or 4.1. So we inflated the 4.0 by 12 up to, I think it was probably 14 to 16 atmospheres. And then this is our final picture. So we thought we had a pretty optimal, great result.
It is beautiful.
It is interesting that with the LV unloading, that lateral wall looks a little peppier than it did at the beginning of the case.
Mm-hmm. I agree, and there was more distal flow too that was notable too. It's like once we opened it up, those vessels really liked having that flow and really opened up.
And the left to left collaterals you see all the way now to apex.
Yeah. So the patient was undergoing cardiac rehab and had resolution of their angina. Kept them on their obviously kept them on their anti-anginal therapy, but the patient's been tolerating cardiac rehab, so they've been exerting themselves to an extent, and their anginal symptoms have dramatically improved. So some of the learning points of this, just really the importance of mechanical circulatory support in patients with last patent coronary conduit. So one final remaining vessel is what I titled this presentation. And also in the setting of a severely reduced ejection fraction of 20%, and then also somebody with severe calcification, that you're going to be doing extra plaque modification, In this situation, we did shockwave, but especially it becomes important in patients where you're performing rotational atherectomy. So MCS was very important in this scenario. And then also the use of intravascular ultrasound to really help guide lesion prep, because lesion prep is what helps us deliver the balloons to set up the final two-stent technique. So we were able to pass and deliver the balloons and stents very, very effectively because of this. And then also, choosing the DK crush in this scenario was very helpful. We were able to, maintain main vessel, main branch wire throughout the procedure, and had a great result.
Would anybody, in the absence of demonstrative viability, open up that LAD in this young person?
Yeah, I admit that I'm a little bit greedy. When you have Impella on site and you have time, I will try 10 or 15 minutes to wide the LED. And I agree with Dr. Sigurua that when there is some penetration of the dye contrast through the CTO down TB1, TB2 flow down distally, there should be at least some viable of myocardium. I don't 100% believe on MRI. I will try at least 10 minutes to wide the LED.
So Alex, I might, have the discussion and consider, 6 to 8 weeks after this procedure, attempting to open the LAD. How old did you say the patient is?
They were 63, so pretty young, very young.
Yeah, I think I would give it a go.
Yeah. I know
wouldn't with the right.
I'm excited about it.
But the LAD I would attempt to. And I think, most times as, we talk about, the magnitude of improvement in EF leaves us wanting. But given how young this person is, if we had sent the person to bypass, they would have put a lima on it. So I think reasonable attempts to revascularize are not unreasonable.
Okay. Yeah,
I do like that for saying reasonable attempts are not unreasonable. Questions or comments for Alex, or would anybody have chosen a different technique to approach that 111 complex last remaining vessel?
Actually, that's Alex showed that's a great case. Just only one comment. When I deal with circumflex, I may use the M-Plus guiding catheter instead of the EVU, at least to help to reduce the angle between the guiding catheter and the coaxial between guiding catheter and the proximal circumflex by using M-Plus AL1. That is one different point.
Yeah, people like you and me love the implants. People like Alex and Hirsch and Jeff love EBUs and XBs.
I would like to try using a AL for a for a case like this.
We'll do that on our next one, Alex.
Yeah. No, that is a great idea though, because it would help things become more coaxial with delivery and retrieval of the stent.
I remember 10 years ago when we have the virtual cath lab, we try to introduce how to manage to guide M-Plus to the virtual cath lab. I remember that should be from Boston or from Abbott, the virtual cath lab, by using every interventionist must pass the examination of using this virtual lab to change the multiple shape of the guiding catheter.
So we used to have the steam gun in the room back when the catheters were truly woven Dacron, and we would heat steam and reshape catheters when we couldn't get in. I haven't done that in a while.
I'm Googling all this right now to see what it looks like.
Well, Alex, thanks for sharing that case. I agree. MCS was essential to provide the patient the hemodynamic instability and to provide the operators the necessary time to do plaque modification and complex stenting technique without the patient crashing.
I asked you, Alex, when did you remove impella? Immediately after finish the PCI or one day later?
Yeah, that's a great question. So we actually were able to remove it right after the procedure. So you have the impella set to its highest flow rate. So that would be P8 during the procedure, or whatever's maximally tolerated. And then you wean it down to P2 as you're pulling back across the descending or into the descending aorta, and then P0 right before you pull it out, so that you don't have any blood flow that leaves and I guess sprays. But yeah, so it was able to be removed before the patient was transferred to the ICU for overall observation. If the patient was unstable, we would keep the impella in for about, up to 24, 48 hours. Like if this was a STEMI scenario, for example.
Wonderful. Alex, appreciate your taking time out of your day in the lab to spend with our friends in Thailand and myself here.
Oh yeah, my pleasure. This is great. I had a great time speaking with all of you.
Alex.
Have a wonderful evening, Alex.
Okay, you too. Bye.
Bye-bye. So in July, I'll show you, I think the first case is scheduled for mid-June. And so I'll just show you some quick images that may or may not include coils. Time will tell.
When I use stent boost, I use old fashioned. Just take your telephone and take the picture snapshot to make sure that the picture is not disappear.
So you occasionally have the same issues that our gremlins are currently messing with us.
Yes, I always convince our technician to transfer the image to PAC. But in some case, very interesting, let's say like stent fracture, when you deal with in-stent restenosis and you are suspected of stent fracture, I'll do stent boost first. And if the picture is very, very fascinating, I'll use my phone, take the snapshot before they delete everything. Then you lose the good picture.
Yes. Yeah, I really value the stent boost feature and use it frequently as I'm working before my final IVUS.
And one of my comments for Alex, I guess he left the room. When you use the pod balloon 4x12, if you look at the overhanging edge of the balloon at the marker, that is a little bit long. But in Thailand now we have the Chinese brand we call Pod PCI balloon. I don't know that it is available in US or not, but
Not
it is
yet.
just only 0.6 millimeter. It's very, very punctual, very accurate. And by OCT, you will gain without edge dissection. Because when you do POT, sometimes the balloon is protrude outside the stent. And this is one of the advantage of the new technology on device innovation.
Yeah, I can't
quite
wait
hard,
till we get it.
quite hard nowadays with the trade between China and US to get
Yes.
it approved. So anyway,
Approved
thank you,
and then
Prof.
tariffed, you know. I thought that we were done with the days of tariff, but I think they're back.
Prof, thank you very much for 2 cases today. We learned a lot as always, and we hope to see you soon.
Wonderful. And then I think sometime in the midsummer, we'll gather to plan the wonderful visit to BDMS in terms of itinerary. I think we received the request for the types of talks, and both Ross and I are excited to provide those talks in the BDMS symposium.
Yes, right now we are owing you the response back from the scientific committee through Dr. Damrat and Dr. Kriengrai. We don't see the problem, but we let them confirm in black and white. Thank you very much for proposing that. Thank you.
Oh, you're welcome. We're very excited.
Thank you, Prof. And see you and everyone. Bye.
Thank you very much. See you. Bye-bye.
Guys. You have a beautiful day, everybody.
Popcorn clap.
Bye-bye.
Thank you so much.